Hello and welcome to the AANMC webinar about understanding heart disease risk, advanced cardiac biomarkers in naturopathic practice. My name is Dr. Yanez and we are pleased to have you with us. Before we begin, please make sure that your control panel is expanded. There should be a box in the upper right-hand corner of your screen to expand. If you don't see this, look for a double arrow. Click those and your box will expand. Second, make sure that you can see the desktop, which should show Dr. Smith's PowerPoint presentation. And make sure that that is visible to you. At the end of the webinar, there will be opportunities to ask questions. Please note all attendees are muted, so type your question in the box down below on the right-hand panel in questions. And please indicate if your question is for Dr. Smith or for myself with the AANMC. We will try our best to address as many questions as possible during the Q&A period after the presentation is concluded. Please feel free to send any unanswered general questions to info@aanmc.org. That's info@aanmc.org. However, if they are specific to the presentation, we may not be able to address them outside of the time constraints of this webinar. So that said, we will try to answer as many as we possibly can during the 1 hour of this webinar. If you have any technical problems, you can communicate with me in the question box as well. I'll try to help you resolve anything that comes up. So you'll be hearing from Dr. Fraser Smith today. And Dr. Smith is a naturopathic doctor who trained at the Canadian College of Naturopathic Medicine in Toronto, Ontario. He is the former dean of the naturopathic program at CCNM, and in 2006 he helped National University of Health Sciences in Lombard, Illinois, launch their Doctor of Naturopathic Medicine degree program, which is now a fully accredited program. He's currently the Chief Academic Officer of the ND program, serving as Assistant Dean for Naturopathic Medicine at the NUHS College of Professional Studies. I will now turn the presentation over to Dr. Smith. It will take us just a moment to transfer screens. Please bear with us.
Well,
Fraser?
Good afternoon, everyone, and thank you very much for attending our webinar today. And thank you, Dr. Yanez, for your introduction. I assume you can see and hear me correctly. We'll jump in here and take a look at our topic. But while we're discussing this topic about predicting an individual's risk for heart disease, I also want to share with you a little bit about naturopathic medicine, which is an important career choice that you're considering right now. So let me just maximize this. Excellent. So my background is naturopathic medicine, but recently I've done some advanced studies in training and development because a large part of my work involves preparing the future naturopathic physicians that will join our profession. I chose to do a residency at CCNM in Toronto, which increased my knowledge of naturopathic family practice. I hold my license in Vermont, am a faculty member here at National University and Assistant Dean for Naturopathic Medicine. All right. So, as a career choice, I was drawn to naturopathic medicine because I wanted to get into health sciences and I wanted to help people get better, but I felt like the existing medical system was really just treating people's symptoms. And that could be a tremendously good thing, but just from my own experience and that of watching family members, it seemed like no one ever asked the fundamental question: how did this person get sick? Why are they presenting with symptoms like this? Why are they sick when other members of their family aren't? I always wondered about those things. I didn't know about this profession until a family member of mine was very traumatized in a very severe automobile accident, which she survived, but developed a chronic pain syndrome. And I saw her suffer and then start to make substantial progress. And she shared with me that she was seeing a naturopathic doctor. And the amazing thing about that is that they helped her heal herself through multiple methods. She was doing exercise, she changed her diet, she was getting shiatsu and acupuncture treatments, she took something called homeopathic remedies, and some of her symptoms actually intensified and then began to disappear. And I watched her essentially heal herself, which was an incredible thing. It showed me what the naturopathic model could be. And it isn't that other practitioners hadn't helped her, because they had, but this was an approach that created the conditions for her to heal. And she healed psychologically. She lost her fear of driving and began to drive again. And she started working out and actually weight training about 9 months later from someone who is almost an invalid from neuropathic pain. So it was quite an amazing experience. Botanical medicine is an important focus of mine, certainly a very effective kind of therapy, and I love all of the therapies of naturopathic medicine, but I love botanicals because they have this wonderful ability to heal the whole person, to almost educate the body, but we can also study what their pharmacology is, and there's so much information about that. So it's just a very rich, very rich field of study. Very quickly, my weekly routine, I spend a large amount of time with the curriculum and our student needs here as the program director. I try to read at least 5 new articles a week on a good week, sometimes more. I'm working on 2 textbooks right now. One is the 2nd edition of my own textbook, and completing a 3rd nutritional textbook for the public. I help out in clinic a day a week, and spend a lot of time with my family. I have good balance in my life right now in that sense, and sometimes I have to pull, a very, very late night session. That's part of being a professional, but I try to have some pretty good balance overall. So here's a case study for you. A 44-year-old male presents with a family history of coronary artery disease. Father who develops coronary artery disease and has a heart attack in his early 50s, the patient reports, and the mother somewhat later in her 70s presents with congestive heart failure. Hypertension in several family members paternally. This individual has had just recent elevation of LDL cholesterol. So the standard therapy for this patient would be go on a statin, essentially. But is there anything else we can know about this person? We know that there's essentially at least 2 major risk factors here. But this is a fairly young man. What else can we know? And this was an area that's interested me for a long time. About 5 years ago, I began to study and work with representatives of the Cleveland Clinic, whose Cleveland Heart Lab division has some very advanced testing for heart disease risk. And so for this individual, we did a Cleveland inflammatory panel. I'm just going to describe to you what kind of things that's involved, and also point out to you that there are other labs that do this testing in addition to Cleveland Clinic. As we get those results in, most of the parameters are within normal limits, but something called the plaque test is high normal. I'll show you what that means. The clinic put him on a Mediterranean-style diet, recommended fish oil and a supplement called resveratrol, and he'll get follow-up testing this spring. So what about this individual? Do we know what's going to happen to him 10 years from now, 5 years from now? And the answer is there's a fair amount of information that we can actually get. Heart disease, cardiovascular disease, cerebrovascular disease, very serious. You can see that heart disease is the leading cause of death in the United States, and stroke is number 4. So combined, they're very, very huge. According to the New England Journal of Medicine and a landmark, the Jupiter trial, they point out that cholesterol itself, high cholesterol, is not a sufficiently predictive factor for cardiac events. Of all people who have a heart attack, a myocardial infarction, nearly half had normal cholesterol at the time. Now, they might not have 10 years ago, but LDL cholesterol, although it's a really important risk factor, doesn't give us the information. It doesn't give us a kind of GPS location of where that individual is on the spectrum of heart disease, from perfect and normal and young to at high risk of having a cardiac event maybe in the next year or two. And that's not a good situation to be flying blind in that sense. Now, here's the Cleveland Inflammatory Panel. This is the one that we use here at the clinic at National. Here's some of the players: myeloperoxidase, the plaque test, high sensitivity C-reactive protein, urinary microalbumin, oxidized LDL, and F2 isoprostanes. I'm just going to describe for you what these entail, just in a general way. And what I'm trying to do here is just to give you a sense of what the sort of 360 study of coronary artery disease we can make just with a simple inflammatory panel. Now, here's a schematic type of diagram of an artery. One way of looking at this is to say, here's a completely open, clear, healthy artery. So here's how we were when we were all 11 years old. No lesions at all. Here's the artery of somebody who has advanced coronary artery disease. And here's the terminal event, which is a blood clot, a thrombus, which of course blocks the blood flow and leads to destruction of heart muscle cell tissue, a heart attack. Along the way, you can see that certain events have happened. The lining of this artery began to change in its function. An inflammatory process began. And a deposition of white blood cells and cholesterol and other components begins to appear under the surface of the artery. As that grows, these are called plaques, atherosclerotic plaques. As they grow, not only do they start to pinch off the blood flow, but they become more unstable. And what ultimately happens is, usually before there's actual cutting off of blood supply, is there a rupture of one of these plaques. So they get big, they become unstable, they rupture, and that is what triggers a blood clot. So it starts with inflammation and a process called oxidation. So there's, and that's very much lifestyle driven, risk factor driven, and that begins to change the inside of our arteries. As the disease is initiated, these plaques begin to grow, and then they become mature and vulnerable plaques. Eventually, acute coronary syndrome is where a lot of these patients end up. So the panel that we're looking at today looks at a spectrum of events beginning with changes to the lining of the artery, to the upswing in inflammation, which is really the model now for how this disease works, eventually to specific markers of where that inflammation is coming from. How hot are these plaques? How inflamed are these plaques? And what's the velocity of their growth? And that's kind of what we're looking at here. This is all very important. In one sense, these inflammatory markers here tell us something about how speedily someone might be progressing from just having a few risk factors to actually having changes in their body. But on the other end, these parameters here tell us something about someone's risk in the next year or two. The classic lipid panel that some of you listening today might have already had is useful, but it really tells us about risk across decades, a lifetime really. And these are tools that tell us something about the velocity of these changes, but also near-term risk, which is really important for some people to know what their near-term risks are. So some, or probably many of you listening today, haven't studied a lot of pathology, so just to help you visualize with that early oxidation or change to the vessel lining, there's initial damage. and a damage that begins to attract LDL particles, the so-called bad cholesterol. As that increases and those LDL particles become deposited, we begin to see fatty streaks and cholesterol deposits. Eventually, these become very large and prominent. This is dissected out of an artery, but give you a sense of how much our arteries can absorb of this. And eventually, a thrombus can occur, and there's scar tissue, a dead muscle cell and scar tissue that takes the place of some of the normal heart tissue, or the heart can seize up and cease beating. So here's one of the early changes that we are looking at. F2 isoprostanes. These are compounds that show up when there's a lot of oxidative stress. And oxidative stress is a cause of tissue damage. It's a normal phenomenon in the body. When there's too much of it, it shows that there's damage to tissues, and the body's not really able to neutralize these compounds. Oxidative stress is this shows there's very chemically reactive oxygen or other molecules that can damage tissues, damage cells, and damage DNA. So this is a sign of tissue disruption, and it's very associated with lifestyle factors, eating a very high-fat diet, eating a lot of burnt foods, certainly cigarette smoking and tobacco use. That will drive up your oxidative stress. And this particular marker actually is specific to the lining of the artery. So we can now see how quickly the aging process is starting in someone's arteries, independently of looking at their LDL level. Individuals with the highest F2 isoprostane levels have a 30-fold increased risk of developing coronary heart disease. Doesn't mean they all will. There's other mitigating factors, but it's a very important early marker. Here's another one, which is oxidized LDL. We know there's an association with having LDL cholesterol and heart disease. If it's really high, your chances are greater. Oxidized LDL tells us how much of that person's LDL is now in a very dangerous form, because this is really the damaged LDL that is really attracted to the artery, that will really collide and impregnate itself into the artery and help grow those plaques. So this is another important parameter. This being high shows several-fold increase of developing coronary heart disease. And so it's not just LDL, but what's the condition of that LDL? And there's lots of literature supporting this. It's important to us to know this as well. Another way of looking at this as well is there's some debate going on about should people with normal cholesterol be given statins so that they can develop very, very low cholesterol because they have a family history, in the sense that, well, the less cholesterol, the better. In naturopathic medicine, we would weigh that argument, but also say that you need cholesterol for virtually all cells, all cell walls, for synthesizing hormones. It's needed in the body. It's important to know what's the state of that person's cholesterol metabolism, not just to try to eliminate a biological molecule that's supposed to be there. So this gives us more insight. Now, allopathic physicians and naturopathic physicians are very interested in this marker. C-reactive protein shows that there's inflammation. It's not specific to heart disease, but it's very useful to see. And so your CRP can go up if you had an infection, but elevated CRP plus elevated cholesterol can indicate a worse prognosis in terms of developing coronary artery disease. So CRP tells us that there's inflammation going on. And interestingly, it's been found that statins, like Crestor, lower CRP. Now they do some other things too we don't like so much, but one emerging hypothesis is that the whatever benefits statins do give some populations, like middle-aged individuals that have already had a coronary event, it might be due to their anti-inflammatory effects more than their impact on cholesterol. So it's an emergent question. Microalbumin is a sign that the kidneys are leaking very, very small amounts of protein, and this is used as a way of looking at vascular damage. The blood vessels in the kidneys, at the point at which we filter our blood, are very, very fine, very discrete, very fragile, and the leaking of protein is like a window into what our very small vascular beds are. The retina, the back of the eye, is another such place. The earlobe, interestingly, there's various places where we see kind of close up what our vascular system is like, but microalbumin is on the panel for this reason. The last two, myeloperoxidase, or MPO, measures the amount of vascular inflammation due to white blood cell response to damaged arteries. So it's showing that there's a wound, if you will, or an actively inflamed area in the arteries that is drawing in the attention of the immune system. And the higher this is, the greater someone's risk of a near-term coronary event. And this is why we like to do this not only for individuals with long-term risk, but for individuals that have had, high cholesterol for a long time, or stroke-like symptoms and things like that. We definitely want to run an MPO on them. And even in healthy individuals, there's significance to knowing that MPO levels are very, very high. So even in someone who seems to get a clean bill of health, their cholesterol looks pretty good, their MPO might tell another story. And certainly, again, knowing what the possibility and possible severity of a heart attack is going to be. Now finally, the plaque test, lipoprotein-associated phospholipase A2, that's just a very long way of saying the inflammatory enzyme associated with those lipoproteins, like LDL. So what this tells us is, again, how much inflammation is going on inside of artery walls, and it indirectly tells us how unstable plaques might be. So a really high plaque test, it's not telling us how thick those plaques are, or how a test called an angiogram will tell you that better, where doctors use a dye and a kind of x-ray to show you where your plumbing is blocked up, if you will. But this tells us, well, the cap or the lid that's on top of these plaques, how likely is it to blow off? How likely is it to rupture? Because those are very, very dangerous events. We saw that can be the final event that leads to a heart attack. So to look at it in a visual sense, here's a stable plaque. A lot of people live through their 80s with lots of these and have minimal symptoms. They die of something else, cancer. So there's a pretty good sealing off of this atherosclerotic lipid plaque. Here's a rupture-prone plaque where it's actively growing, and there's actually a very thin kind of abnormal lining on top of it. It's arterial lining, but it doesn't function like it's supposed to. It's very inflammatory. And then the event, of course, is a rupture and a blood clot. And if that's large enough, and if it's not resolved quickly, that can shut off blood supply to part of the heart. So just to recap, we're really looking at how quickly someone's arteries are aging, what their localized inflammation is, and also what the growth and instability of those plaques are, because we certainly hope to prevent this event here. Very, very quickly, some of the other things that we do look at with patients are their particle size. So not just how much LDL they have, but the particle size, and that really matters because different particle sizes, different sizes of LDL have different level of risk for patients. So someone with many, many smaller particles, even though the total LDL count on their lab test, typical lab test, might look normal, they actually have a more dangerous type of LDL. So we want to know that. So I always, think twice about assigning goodness or badness, or friendliness or unfriendliness to cholesterol. I guess sometimes it depends, like in this little cartoon here. But there are different types of LDL, and you've probably heard about so-called good cholesterol, which it often is. So someone will say, well, my bad cholesterol has gone down and my good cholesterol is still pretty high. That's high-density lipoprotein, which is usually helpful. It takes cholesterol from arteries back to the liver. But under those high inflammatory conditions, where there's, say, markers like myeloperoxidase or MPO are high. So in those highest risk situations where there's a lot of inflammation, the HDL particles are actually damaged, and they no longer are useful. They no longer remove cholesterol. In fact, they just begin to behave like an LDL particle. So not only are they not lowering risk, but they dysfunctional LDL, HDL as it's called, can become something of a menace itself. So again, the standard lipid panel is useful, but it's incomplete. And these kinds of tests help us get a better picture of what to do. There's just some references if you have an interest in cardiology, etc. So when this patient is reevaluated, what we really want to see is that he's above borderline high, normal to high on his plaque test, and that his cholesterol is within normal limits, but also that there's really no indicators for inflammatory activity. That's our goal. Given his family history, that's our goal at this time. I just want to talk a little bit about practice success and then open everything up to questions, so we have lots of time for that. Questions are always fun, and we always get so many great ones. If you are choosing a career in naturopathic medicine, here's some things that you could actually start to do now, or certainly when you begin medical school. What actually you should start to do now, which is think about what kind of practice you want to have or what kind of work situation you want to have. Do you want to have your own business and be your own boss and be in control, serving your clients, but in a situation where you're the manager, you also assume the risk for the business? Do you like being on a team? Would you rather work for a larger institution like a hospital or a university? Are you interested in research? Think about that, because that really does influence some of the choices we make. And it's not too early, even though this can change, it's not too early to think about what will I do with this degree and what makes me happy? Would I be lonely and unstimulated out there all by myself somewhere, or would I feel constrained and cooped up and overmanaged if I had to work for someone else? We all have different personalities, and you want to find the shoes that fit here and really look at yourself honestly. In school, certainly start planning your plan and ask practical questions. You know, how will I fund a practice startup? Or if I'm going to join others, how should I do the networking to get there? Should I go and spend time observing in people's offices? Should I take them out for lunch? Should I go back to my home state or the state I plan to live in and every summer and get to know people? Prepare and do additional things. The naturopathic training is very comprehensive and very complete, but there's always other things that we can learn or do beyond that, such as getting to know the business climate and medical climate of a place where you might want to work. You know, where are the good locations? Where are the successful practices? Where do people get their health care? What's the local hospital like, etc. Focus while you're in school. There's always diversions, and it's not always going out to a movie or something like that. Sometimes the diversions are unnecessary competitiveness with others or getting hung up on a prof that rubs you the wrong way. It's really a short time to learn so much. So focus and get every single thing you can out of your ND education. You'll never have another time like that in your life where you can sponge up so much knowledge. It's really important. Strive and don't limit yourself to self-imposed limitations, and persist and not give up. Ask yourself, be true to yourself in terms of what you like and what you want and what you're doing, and don't forget to have fun. Even though it is pressure and it's a lot of work, if it feels like drudgery, if the minutes are ticking by most of the time, something's definitely wrong. So if this is a good choice for you, have the right attitude about it, and constantly learning, constantly striving. I can say this is that I really have never been bored since I got into naturopathic medicine, and have had very fulfilling experiences, very challenging experiences, but my wish in my early 20s to not just roll along with the tide, but make a difference and be challenged and be growing and be learning, that's come true for me. So it's important to have fun while we're helping others. So a big thing for me right now is to see our successful licensing efforts continue even further. I'd like to see naturopathic medicine available to everyone, and also a greater research agenda for our profession. So it's exciting time as we're really hitting our stride in many, many ways in our profession. So I'm going to open things up to questions and hand things over to Dr. Yanez for the moment.
Thank you so much, Dr. Smith. Before we begin the Q&A session, I'd like to let you know about our upcoming AANMC virtual fair. This is an online free event where admissions representatives, faculty, and students from the accredited naturopathic member schools will all be available all day long. It will take place on April 15th from 8 a.m. to 5 p.m. Eastern Time. Some of the schools may actually be on a bit longer due to time zone differences. If you can also request information from me at info@aanmc.org. We will also be hosting a May webinar on adrenal reset and fatigue with Dr. Alan Christensen on May 27th. So again, please check out our events page and stay tuned for all the AANMC events. So with that, Dr. Smith, I will let you know about the first question. So let's see. Zaida wants to know how calcium builds up in arteries.
Great. Excellent question. I can see you were studying the diagram. Calcium is an end-stage phenomenon. So when something is calcified, it essentially shows that there was inflammation, some scar tissue is formed, and the body has tried to stabilize it or strengthen it as best it can. So sometimes if you keep ripping a tendon in your shoulder, eventually it will calcify, which is kind of a painful condition. So a calcified artery is actually a very bad thing. It's stiff. It doesn't expand along with the beating of the heart. It leads to high blood pressure. It's easily damaged. It shows a really aged out artery, and that's really a late stage phenomenon. So you definitely want a low calcium score intracoronary vessels. Great question.
Next question is from Leah, and it's in regards to exercise. So can exercise cause a lot of oxidative stress? And if so, what can be done to mitigate that for excessive exercise?
Yes, it can. And sort of the exercise, we recommend for most people might transiently elevate it, but it's not significant. However, elite athletes, really high performers, folks who are training several hours a day, they actually have a very high MPO, and that can perhaps cause some aging, even though they probably have incredible cardiac strength and great vascularization, lots of collaterals between their blood vessels. It can cause some aging. It's almost like their metabolic furnace is turned up to broil, and there's the MPO is a sign of this. So, activity avoidance isn't really a realistic recommendation. So, some of the supplements and dietary changes that would treat this would be the recommendation. That might mean a more Mediterranean style diet or DASH type diet, but also things like greatly increased vitamin C intake, just good old ascorbic acid, or some of the plant compounds that are known as polyphenols. We'd want their intake of those things to go up, which frankly you can often just get from eating more fruits and vegetables. But we have some we have some nutritional supplements that, like green tea extract, that can really deliver a high dose of those things. But for most of us who get enough exercise to be fit and take care of ourselves, it's not really a big impact on oxidative stress.
Okay, next question. What types of things can cause an elevated CRP?
Well, in addition to blood vessel inflammation, infection can. So even something as simple as strep throat that's been hanging around for a couple weeks, or an abscess somewhere in the body, autoimmune, like rheumatoid arthritis, or something where the immune system is activated against some part of the body or some tissue of the body. So CRP is not exclusive to the heart. So anytime you're certainly, it's really useful, but not.
Dr. Smith?
Yeah, still here.
You were cutting out just a little bit.
Oh, I heard a little bit of a noise distortion. Am I coming through okay now?
You are. Mm-hmm.
Great. So if I got cut off there, we can go through that question again, but hopefully that came through pretty good.
Okay. Okay, so there is a question in regards to treatments. Where can people find additional information on treatment options for the abnormals?
You know, a good source. One of our naturopathic publications. There's some good things out there, like there's really good resources available to everybody, like the DASH diet that you can read about, Mediterranean or Mediterranean-paleo diets. Anything with lots of fruits and vegetables is usually a good start. Really specific protocols is a good thing to consult with someone. Although you can get some general protocols from books like the Encyclopedia of Medicine, cardiology books. A lot of folks have things like You, the Owner's Manual by Dr. Oz, etc. And a lot of the kind of common advice that comes from shows like his, or some of the popular websites, a lot of it makes a lot of sense, like omega-3 fatty acids more than the vegetables a day, drinking green tea. But to get beyond that into really high doses of specific nutritional substances, it's worth speaking with a naturopathic physician, or certainly an integrative physician or chiropractic physician that has some advanced training in that area.
Okay. Can you speak about the types of insurance coverage and costs associated with some of these tests, and if insurance does cover it?
It often does. It kind of depends on the clinic too, but from what I understand, a lot of insurers will cover it, simply because it's preventive. At our clinic here, I think I would actually have to go and look, but I think everything on that menu, some patients get a, as we'll say, a la carte. So say if we're just redoing someone's plaque test or something, it's less than $50. So not much more than, say, a night out for my wife and I. And if I include babysitting, it would actually be cheaper. So to know what your more insight into what your actual risk of having a cardiac event are. It's well worth it, in my opinion. But you know, a lot of folks are stretched to the limit with bills and expenses, and it's nice when insurance picks it up. And from what Cleveland has told me, a lot of insurance does, but they also for a lot of clinics that charge this on a cash basis, that they usually work something out, and it's affordable to a lot of patients.
Okay, Dr. Smith, beyond diet, are there specific treatments for abnormal plaque?
You know, if somebody already has plaquing there, I think their best bet is to lower the inflammation. Or in other words, can plaques regress? There's a little bit of evidence that they can under a really, really tight dietary control. There's an experimental therapy called chelation therapy, which kind of uses a compound, an intravenously administered compound, to try to dissolve calcified plaques a little bit. It seems to reduce symptoms of angina, of chest pain, but its ability to really shrink plaques hasn't been proven. Some studies using really, you know, I don't know about beyond diet, but very, very low-fat vegetarian diets, a small group of patients, possibly regression of plaques, Dean Ornish's studies. But beyond that, it's really a question of botanicals such as resveratrol extract, or cocoflavanols, which is actually derived from chocolate, which is good news to a lot of patients, from dark chocolate, can really decrease that inflammation. And that is important because although plaque size is important, plaque activity is probably more important. So there's a certain stage in this where if someone gets these things under control, their risk of actually having a cardiac event goes down substantially. So they may not make it to the age of 90 with absolutely pristine arteries, but if they don't have symptoms or they don't really have problems until they're very old, that's great, versus having things start to fall apart in their early 60s. There is a point in all of this where cardiac interventions come into play, cardiac bypass and grafting, and I've seen that take people from just absolute heart failure to just having great cardiac perfusion and great looking skin and being able to exercise again. But none of those procedures last forever, so we do our best to get to the underlying cause, whether someone's going to have a high-tech intervention or not, because it's going to catch up to you for better or for worse down the road, and inflammation seems to be the key here.
Okay, next question. Can you describe some of the genomic testing for cardiovascular health?
Not in great detail. It's not a big interest of mine right now, and it might be something I learn about in the future, but I wouldn't be comfortable lecturing on it right now. Genomic testing in general, it's still very young, and it's going to become more specific. There's some cancer markers that are actually pretty good. There's probably about 20 or 30 cardiac biomarkers. Some look at nuclear transcription factors. Some look at really discrete antioxidant enzymes that are all under experimental development. I suspect 10 years from now there'll be panels for those too, and or maybe sooner.
Dr. Smith, there are a couple questions about the Cleveland panel you used. If you can specifically talk about the normals, or if there's a link that you would recommend.
If you want to learn more about it, just from the sense of self-education, your own edification, Cleveland Heart Labs has a terrific website with a lot of open access. So if you just Google Cleveland Heart Labs, they'll give you lots of stuff. Some of it is more meaningful if you have some deeper education in other areas, but it's quite extensive. They actually are extremely generous with some of their information. And you can find such things on PubMed as well. I mean, Cleveland Clinic is an aggregator and something of a researcher in this area, but a lot of it is just in the medical literature in general. And in any lab, if you have one of these panels run on you or a loved one, the lab report will always show you what the normal range is supposed to be and where you stand relative to that range. So it just kind of comes along with the report.
Dr. Smith, do you also consider psychosocial issues in regarding cardiovascular disease?
Oh, absolutely. I think those psychosocial events can drive up inflammation, but I also believe that stress can play a huge component, not just sort of healthy, normal stress that most of us need in order to feel engaged and feel motivated. I think we all have the feeling sometimes we just like to be on the beach and live a life of leisure, but a lot of us would be deeply unhappy after a while. I don't know, maybe I should speak for myself, but higher levels of stress. So some of our patients we've had in that are losing their house to foreclosure, their marriage is breaking up, their employment situation is unstable. Those sorts of sustained situations, if it's really grating on someone, that will can elevate their inflammation, that can raise their blood pressure. It can lead to behaviors that undermine their health overall, like not drinking enough water, overindulging in alcohol, lack of sleep, difficulty relaxing, eating the worst possible food choices, just out of a sense of comfort or self-medication, so eating fast foods and fried foods and high sugar foods. So all of those things can happen. So and we know that the body changes when it's under stress. There's measurable hormonal changes, and I think that has a lot to do with it. We should never get too fixated on any one parameter, including the inflammation panel or advanced lipid testing, which is why we are kind of old-fashioned in naturopathic medicine. We still insist on doing a really good patient interview, respectfully examining them, touching the patient, getting to know them, and not just because it's a ritual, but because there's important things you can learn about someone you can't always get from one blood test.
Dr. Smith, we have a question about the role of sugar in inflammation.
Sugar indirectly can rise up inflammation. It depends on the amounts, and it depends on where that sugar sits in relation to the rest of the diet. So I'll give you an example. Let's say that someone has a Danish for breakfast and then at lunch has a hot dog in a big gulp. So they've already had about 24 teaspoons of sugar. That sugar slams into their bloodstream. There's no fiber or no fat really in those foods to slow that sugar down. There's nothing to digest. It's just pure refined carbs, pure refined sugar. As you're probably familiar, that will cause the hormone insulin to be excreted very, very rapidly. And elevated insulin for sustained periods of time, sequentially, repetitively, can start to cause more inflammatory events. And it's not a one-off. Someone who eats a healthy diet that goes out for a strawberry sundae, their insulin will soar for a couple hours, but it's not a pathological issue. But with the diets that we see with a lot of patients that shop the center of the supermarket, eat the processed foods, skip meals, eat a lot of refined processed choices, they're in this high insulin state. And over time, that can uptick some inflammatory processes in the body. So it's not a natural state to be in, and it probably wouldn't exist if we didn't have unprecedented access to big quantities of refined grains, refined seed oils, things people used to have to work really hard to produce in the past, but we have coming at us from all directions.
Can you speak about, there are a few questions in regards to food, either for people who have low cholesterol and what they can do in a healthy way to raise it, or to normalize LDL and HDL levels?
Well, I think an important point there is something that's now being acknowledged in the conventional literature, which is, eating cholesterol doesn't raise your cholesterol, and eating fat doesn't make you fat. So it's an important starting point there. I'm hoping that 5 years from now, I won't have to see anyone else who's afraid to eat an egg, who's afraid to eat a poached egg because their doctor scared them out of it because it'll shoot their cholesterol up. Cholesterol is mostly manufactured in the body, and diet can raise it, but particularly an imbalance in the type of fats that we're taking into the body. So someone who's getting a lot of corn oil, safflower oil, hydrogenated fats, which fortunately are becoming a little less common, and not enough healthy oils from things like flaxseed, fish oil in particular. People who have an imbalance there, and many people do. They have about a third of the omega-3 essential fatty acids in their diet that they ought to. That's really a huge problem. So in terms of lowering cholesterol, I mean, a simple thing people can do is, yes, get their intake of saturated fat under control. But the question is, do they need to eat an ultra low fat diet? That's quite debatable, and I would say, with a few exceptions of people with genetic inherited high cholesterol diseases, not really. What they need to do is sort out the ratio of fats in their diet. So if they're eating seafood, if they're eating cold pressed things like extra virgin olive oil, if they're eating flax meal and oatmeal and things like that, that should have a beneficial impact on their lipids. Hand in hand with that, though, is the necessity to eat a whole foods diet. The food author, commentator Michael Pollan, in his book In Defense of Food, says that if you boiled it all down, we should eat food, not too much, mostly plants. Now, that kind of seems like a ripoff for $20 for a book, but it's actually very profound advice. Eating whole foods or actual foods versus processed foods does make a big difference for people in terms of the impact on insulin, the impact on LDL, and eating lots of plant foods is important as well. So getting exercise, but also eating whole foods like legumes, a certain amount of whole grains, and fruits and vegetables, and grass-fed or naturally raised meats, if they eat meat, is a great start. So, what I'd say with that cholesterol control, it's not so much about avoiding carbs or avoiding fats. It's really about the quality of food that's eaten and a certain proportion on our plate between fruits and vegetables and other foods. So healthy grains for many people, but not too much. Healthy protein sources, but not too much. I think that approach is what ultimately can help normalize lipids, but also give someone a lipid profile that's safe for them. They're not atherogenic lipids. They're safe levels of lipids, but also lipids that behave in a safe way. That's what we're after as well. So it kind of takes a global global view of eating and a global view of what's going on in the blood.
Dr. Smith, there's a question in regards to your diagram and inflammation in the vessel wall. And at what point is that reversible?
That's a great clinical question. If there's certainly early changes to just the lining, that's almost totally reversible. If there's a small amount of fatty streaking, small amount of lipid deposition, and someone's still fairly young, that's mostly reversible. Beyond that, because the body locks that damage in with what's more or less akin to scar tissue, some of that's probably always going to be there. Whether it's significant or not is the question. So once you really get into having bona fide a plaque, some of that's going to be in there for the rest of your life, but it may mean absolutely nothing, or only slightly increased risk. Once someone's more well established, that's another story. I'll point out as well that that fatty streaking, we now know that's occurring in preteens and even earlier because of the advent of obesity and metabolic syndrome in the very young. What used to be called type 2 adult onset diabetes when Dr. Yanez and I went to medical school is now a disease of 13-year-olds. So unfortunately that surface change in the arteries is happening to our kids.
Okay, this will be the last question. Thank you, Dr. Smith. We have a question about fish oil and CoQ10. Can you speak to the role of both of those in cardiovascular disease?
Fish oil is great. Just want to make sure that it's good, ultra-filtered, pure fish oil from a good leading manufacturer. And a naturopathic physician can point you in that direction, but there's definite differences in quality. So a good quality fish oil, or eating good ocean-caught fish, it reduces inflammation. It can change your lipid pattern too, but it definitely helps address some of that inflammation. CoQ10 is a pretty good antioxidant, but what it really does is help muscle cells, including heart muscle, function more efficiently. A lot of sick hearts, a lot of diseased hearts have a lack of CoQ10 in their mitochondria, in the power plants of the cell. So I think of CoQ10 as something for someone who already has established heart disease. Anybody on a statin, though, should probably take some CoQ10. There's some exceptions depending on other drugs that they're on. And again, this is where it's important to consult with somebody. But usually they should. Statins stop the production of CoQ10 in the body, and CoQ10 is an absolutely 100% essential enzyme in the body. And unfortunately, statins do what they do to cholesterol, but they delete CoQ10 out of the heart. So for some patients, if they're not on it, they will be because it's so important.
So thank you so much, Dr. Smith, for that really informative talk on naturopathic approaches to cardiovascular disease. We're basically out of time. So on behalf of the AANMC, I would like to thank you for your time today. I'd also thank all of you for attending this presentation. We hope this has given you some new insights into the possibility of following a career path in naturopathic medicine. And for those of you practicing, a little brush up on cardiovascular health. Please note this webinar recording will be archived and available on our AANMC website in about a week. We will also send an email out letting you know when that is ready. If you wish to review the PowerPoint, you will also be given links to this via email as well. So thank you again so much, and on behalf of the AANMC, we appreciate you spending this Wednesday afternoon with us. That will conclude our webinar. Thanks again, Dr. Smith.
Thank you, Dr. Yanez. Thank you, everyone.